You're watching BCTV, Branford Community Television.
Hello, my name's Sue Wharf. I'm the new Executive Director of the Shoreline Village, Connecticut. I'm delighted to be introducing this wonderful talk that Christopher O'Connor gave us last week at the Guilford Community Center. Let me just tell you a few words about what the Shoreline Village is. Our mission is to make it easier for seniors living on the eastern Connecticut shore to stay living in their own homes and be still a vibrant part of the local community. And how do we make this happen? Well, the village movement began in Boston and Beacon Hill about 10 years ago, and we are part of that. At the moment, there are 10,000 seniors in the country getting services this way. How do we do that? Well, the primary way we function is to create a very supportive community of the seniors themselves. We nurture and develop that with a professional staff. We have a website, and we hope that the seniors will actually, with a wider range of ages, be able to engage with each other, providing services such as transportation, companionship, outings, visits to the doctor, grocery shopping. All these will be provided by the seniors themselves. That's what's sort of different about us. We, as the Shoreline Village, Connecticut, with the staff, will enable this to happen. We also provide vetted services to our members. Our members will be able to get a discount because of group purchasing power, and they will get usually about a 10%, but sometimes larger discount for things like roofers, plumbers, electricians, you know, the tree falling on your house. And these, not only do you get a discount, but you have a very good shot at getting a really good person, because we will have already vetted people. A little bit of crowdsourcing will take place, and this way people will know what they're getting. The other part is education and advocacy, and really this also connects in with the community part, and that is what we're doing today, having Chris O'Connor give us a wonderful, I'm sure, talk about what is happening in healthcare on the shoreline today. I'd like to introduce Randy Reinhold. Randy is the leading force behind our village. He has a very long and distinguished career in surgery. He was finally the chief of surgery at St. Raphael's Hospital, which he recently retired from. And this is his endeavor, which we are so grateful to have Randy's wonderful skills and abilities now serving the Shoreline Village. Here is Randy Reinhold.
So, one of the things the village does is sponsor educational activities. So about 2 months or so ago, when I knew that the Yale St. Raphael's deal was closing, I asked Chris if he would come and talk about the integration of the two hospitals and what it would mean for the folks in the Shoreline. And he agreed. We would have added the Affordable Care Act, the Accountable Care Act to the topic at that time, but we had a Republican running around the country saying that they were going to repeal it on the first day of the new administration. So it wasn't clear what was going to happen. Fortunately, at least from my perspective, last Tuesday we resolved that question, and the quote-unquote Obamacare is here to stay for the foreseeable future, and so Chris can address some of that. I actually was the chief of surgery at St. Raphael's for about 15 years, and fortunately for 5 of those years, Chris was the senior administrator for the Department of Surgery, along with cardiology, the emergency department, and everything else. And then he left to go to the Oxford Clinic because they needed him to be there during Katrina, just like they needed to be back here when Sandy struck us. Anyway, after a few years at the Oxford Clinic in New Orleans, he went to St. Elizabeth in Boston, and then returned to be the CEO of St. Raphael's back in 2009. And he and Juan and some other critical people managed to negotiate the integration of the two hospitals. And now we can look forward to see what's going to happen to healthcare on the shoreline. So, Chris?
Thank you, Ryan. So the frightening thing is I'm sitting in front of my mentor, an old neighbor, my best friend's mother, my mother. I mean, so I have to be very careful what I say this evening because you know, there's going to be a lot of lie detectors out in the audience to make sure I'm honest. It's a pleasure, and I think that I'm not going to talk for too long, although I could talk for days about what's going on in healthcare and why I feel so passionately that the integration of St. Raphael's and Yale New Haven is really one tool to begin to move forward to deal with all of these changes that are happening, whether we want them to or not. And I think that there is some great local solutions, and I think the villages is one component of changing the way that we view healthcare. I mean, forever we have looked at healthcare as a per procedure, per episode type of encounter, and I think what we are hoping or aspiring to move to is more of looking at how do we keep people out of the hospital, in their community, and ultimately provide services at an incredibly reduced cost from our current system. So before I get into that, which is the future, I thought it would be helpful to talk a little bit about background. Why did St. Raphael's and Yale New Haven have to get together? I mean, these are two great hospitals. We're in this community for over 100 years. Just for point of reference, I obviously grew up in this area. My mother has been a nurse at St. Raphael's and now with the new Yale New Haven for 37 years. I was born at Yale New Haven because I was a high-risk baby and required some neonatal intensive care services, and they couldn't be provided at St. Raphael's. But I began my work in healthcare at 19, working as an ER tech in the St. Raphael's Emergency Department. I met my wife, who was an ER nurse in the St. Raphael's Emergency Department. So I have a very strong passion for what the mission and values of the Sisters of Charity of St. Elizabeth and the Hospital of St. Raphael provided to the greater New Haven community for 105 years. But I'll kind of rewind the tape back to 2009. I arrived back at St. Raphael's coming from a system in Boston that was in the process of converting from an archdiocesan system to a for-profit venture capital-backed firm, Stewart Healthcare, and when I was at St. Elizabeth's. And I came with the hope and aspiration of staying independent because as the CEO, it's what you like. You like to be your boss and be able to set direction and do the things that drive passion. And unfortunately, 30 days after arriving, and there were no secrets. I mean, having come from the community, I certainly knew what I was getting into. But I was summoned to New York to meet with our bondholders, and we were in violation, technical default, of our debt because we did not maintain certain covenants, promises that we had made with the bondholders to assure solvency. So I was called 30 days into my new job to a bunch of bankers and a healthcare firm that had done a report on St. Raphael's. And it was not very flattering that there was a real question whether we were going to remain an ongoing entity. And as the bondholders, they had certain provisions because we were in technical default. They could call our debt. They could certainly take over the management and ultimately force us into bankruptcy. And there were all sorts of these, doomsday type of scenarios that were presented. So that was a very sobering meeting that I had, within 30 days of my new employment. It's always good to have a long orientation period. And we really began, after that meeting, to talk with the sisters, our board, and the senior management about what the course is going to be. And at the same time, if you recall, if you can kind of rewind the tape back to late 2009, early 2010, it's when President Obama was beginning this debate about healthcare and healthcare reform. And it was also in the time where it was quite uncertain whether there was actually going to be healthcare reform. But the one thing we knew is that at St. Raphael's we had 60% of our patients were Medicare-covered patients, and another 10% were Medicaid. So we had 70% of our patients that were paying us through the government, that we were going to be facing reduced reimbursement. I mean, that was the certainty. So you had state governments under incredible fiscal pressures here within Connecticut And obviously the federal deficits with wars and a great economy beginning to come under fire, obviously really under attack. So we knew we were going to get paid less by those governmental payers. And so we began to work with an outside firm, because in healthcare that's what we do. We hire people who are outside experts that help us. And we really knew that the route to our future was not going to be independent. That it was not a fun conversation, and certainly one that if you were sitting in the room was very emotional. But ultimately, as fiduciaries of the organization, it became clear that we were going to have to find a partner. And so then we began to search. Where are our interests? We began to align what's our mission, what our history, what our commitments have been. And then ultimately, who lines up the best with it? We looked at a number of not-for-profits. We actually had long-standing conversations with some national Catholic partners that ultimately we were trying to figure out a deal even before I came back in 2009 with St. Vincent's and Ascension Health out of St. Louis, St. Vincent's in Bridgeport, to see if that would work. It didn't. So there were some mechanisms already in place, and so we really began to explore who those folks would be. And in the meantime, I had gone out and talked to Marna Borgstrom, the CEO of Yale New Haven, and we had an interesting discussion. Very low-key, certainly nothing that ultimately happened, but it was about how do we align programs. We had maternal fetal medicine programs at St. Raphael's that we were utilizing the Yale faculty to help provide. We were paying a fortune for them. We were not seeing the level of high-risk patients. It doesn't make sense for us to have that service, pay pretty significant dollars, and ultimately not have a viable financial model. Well, the argument is that we were going to be a full-service hospital. We have to provide that service. And so you kind of got in this catch-22. Well, ultimately, you start adding up those services that have high expenses. We don't do enough of to really support our own services on our campus. But together, when you start to look at it, it makes more fiscal sense. So that granular discussion of, okay, starting with MFN, and then going into OB, and then kind of getting bigger and bigger, then ultimately we said, wait a minute, let's start and talk what makes sense. Because in parallel, certainly Marna was aware, and I was very public about the fact that we were beginning to look for potential partners. We had not only the debt that I mentioned earlier, but a significantly underfunded pension plan, like many institutions across this country. So it came at the same time that we're now talking across the country around healthcare reform, the Affordable Care Act. So it passed in this same time period. So it went from being this concept and an appeal and a lot of resistance around the government taking over healthcare, which is somewhat ironic because I haven't seen anybody give up their Medicare coverage yet. But nonetheless, it was in parallel to this discussion. And so we were saying, well, listen, if we're going to be able to provide a service to this community, and community in the broad sense, we're going to have to do it differently. And doing it differently means that we're going to have scale, that you're not going to be able to do it well if you kind of do it in a small slice. And we're going to have to be able to pull costs out of the system. Because right now, Yale New Haven is one of the most expensive providers in the state. As an academic medical institution, that's not uncommon. Well, ultimately, how do we keep those missions going and do it in an affordable way really drove us ultimately to come up with a letter of intent. Now, of course, it took 9 months and a great deal of gray hair, but ultimately we began to say, okay, there are a couple fundamental principles. Yale New Haven was at capacity. Right now, I actually came from a meeting today where there's an occupancy of about 95% on the Yale New Haven campus. So they were growing. Obviously, the investments that they've made, one right down here on Goose Lane, it has been very successful for their institution. They have done very well. So they've been able to invest in services and bring new people in and build around those folks to ultimately grow the product line that they have. And at St. Raphael's, we were struggling. We couldn't invest in our infrastructure and services So we were actually losing volume over that same time period. So you had a lot of natural synergies that just began to take shape, and it made sense. Why go out and work with a for-profit company to come in and invest in our institution? Yale New Haven was going to have to build a bed tower if they didn't do this deal, because ultimately they were at capacity, which would have cost a couple of $100 million. Well, a couple $100 million seemed good for me, and was right in terms of our financial picture. And so we really began to say, okay, how do we work together? And that process was hard. I mean, there was a great deal of emotion through it. We began to look at services and, unfortunately, people that ultimately deliver those services that would be impacted as a result of coming together. And, you know, it was very personal for me. I worked at St. Raphael's for a long time and knew a lot of the names that were on the list of folks that were going to be impacted. I worked with my colleagues that in administration for 20 years, some of them that I've known and have grown up with, and it was very difficult. But, you know, you sit there and you say, what is the right thing to do? And when you look at the alternatives and you look at the goals that were there, and then you factor in some of what the future is going to demand of us, from my perspective, and certainly our board and our sponsors, the Sisters of Charity of St. Elizabeth, it made all the sense in the world to move forward. There were consequences. You don't get, you know, anything in life for nothing. So what did we lose through this transaction? Well, we certainly lost the autonomy. You know, independence is a nice thing. You have the freedom and flexibility to respond differently, and that difference has been, I think, a benefit to this community over our existence. We lost our Catholicity, our official Catholicity. So we are no longer officially registered as a Catholic hospital. However, the compromise there is that you wouldn't know that if you walked through the halls of St. Raphael's. We are still adhering to the Catholic doctrine, which is the ethical and religious directives, which is really the holy grail, no pun intended, of Catholic health care. It still provides services exactly as the community has experienced that provision over the last 105 years, with the choice that you have in New Haven to go to one or the other institution. We could not fully fund our pension plan, and the reason is that when we modeled the purchase price, it would have been fully funded. But unfortunately, what happened from that modeling to the close date is interest rates dropped through the floor, and thus that creates the way that you calculate pension plans. It actually increased the liability, and so our pensioners are, you know, we are all going to suffer a little bit, but not certainly as much as if the institution had gone insolvent in the meantime. So there was about $86 million that has already been deposited into our pension fund to help offset those losses. So that's a significant, almost doubling the size of the fund to help pay off that responsibility. So, you know, all those things were some of the hard things to swallow. The good things is that the vast majority of our employees, 3,500 of them, have been moved over to Yale New Haven and have roles, and you know, there is a vibrant opportunity and center that is doing very well collectively that will continue to provide care for this community well into the future. We are solid. I mean, the great thing for me is we're talking about long-term. How long-term are we going to solve issues? What ultimately is going to be our strategy to help keep people out of the hospital? How are we going to recreate our system that incentivizes people to have surgeries and procedures into ones that provide incentives for people to stay healthy, to make the right choices that obviously right now in our society we don't have, I think, good incentives to lower the cost. So, you know, those things are ongoing, and I think as the President talks now about Obamacare, whether amnesia is covered or not, I don't know, but continues to be covered, that may be excluded. But one of the things is for sure is that together we will have a much more stable platform to address those changes. One of them is what we've called accountable care. And I put an article up here that's it's a little bit dated, but it's an article that anybody can come up, and it talks about what accountable care is. And so these terms get thrown around, and frankly, you go to one seminar, you get one definition, you go to another one, you get another one, and you probably, everybody has their own spin. But essentially what it does is it puts the responsibility on the total continuum of the healthcare dollar to not just the hospital and the doctor, but across the entire spectrum. So when you think of things like the villages and you say, okay, you could get that same care or services sitting in a nursing home at a cost. Mr. Tarutis, what's our cost for nursing home daily care?
About $450 a day.
$450 a day that we, the people, are helping to support. Or, again, when you get to a threshold, obviously you're going to need that level of service. But if you don't, and we can create those services and keep you in your home and come together as that community that Sue talked about, then that certainly is going to lower the cost of care over the continuum. Well, that's just one example. How do we take care of diabetes? It's an incredible comorbid condition for a number of diseases. It obviously has a great deal of cost and procedures related to it. Well, if you can get better management of that proactively, if we can put nurses that actually are calling and engaging on a regular basis with how's your blood sugar doing, are you being compliant with your insulin utilization, those types of interactions. Right now there's no payment to a hospital to do that. There's no incentive for us to invest those resources. But obviously if you put accountable care in place and you say now you're accountable for that whole care process, our incentive is going to be to keep those folks out of whether you need a vascular procedure or whether you need an amputation or something that is much more significant because of the progressive demise of the disease. That obviously is going to really change the paradigm. And I think we're getting there. We aren't quite there yet. I mean, I think our society still expects us to have everything whenever we want it, which is a very expensive platform and infrastructure to maintain. But I think that just by nature of the dollars and the fact that how much we spend, what's it up to now, 17% of GDP, it is an enormous burden on this country to have this system going forward. And it will change. I think it's inevitable that it has to change. It won't change drastically overnight. It will change incrementally. But one of the things I think you're going to see is that more proactive, outpatient, ambulatory so-called care base that will really push those decisions into the hands of not the specialists and the proceduralists in the hospital, but more into the primary care physician's hands. Now, one of the challenges is we're completely undermanned from primary care. It is very difficult to get an appointment, particularly if you don't have good insurance coverage. It's almost impossible to get an appointment, and it's one of those things that we really have to focus on. There have been some modest adjustments from a financial perspective to invest in primary care, whether it's, you can get some loan forgiveness from the government, and they're increasing the reimbursement rates slightly. I don't think nearly enough to entice folks into primary care, but we will need a lot more of it. And I think that you see strategies across this country with health systems, with large primary care groups going to create that network, that ultimately I believe that's where the value of the healthcare dollar is going to start. In the hands of the primary care physician who will be able to deal with those illnesses, the diabetes that I mentioned earlier, in a much more proactive, early onset, and ultimately drive cost out of our system. Manage the use of tests and procedures. We I think average, we have more MRIs in Manhattan than in all of Canada. I think it's more even on Fifth Avenue than in all of Canada. I think we have more on York Street than in all of Canada. So, I mean, we have a high propensity to utilize high-cost procedures. And those things, I think, are built on the incentives. We get paid a lot of money. We make a lot of money on imaging. So when you make a lot of money on it, what do? Keep investing and do more of it. So I think you're going to start to see those things change. I think you're going to start to see hospitals get less money for those procedures. And that's going to push us. Right now at Yale New Haven, We have a $500 million cost reduction plan in place over the next 4 years to pull out $125 million of real costs every year, because ultimately we believe we're not going to be able to be as high cost as we currently are. You know, we also know that we're going to probably invest more in ambulatory care. We have obviously the Guilford Center here on Goose Lane. We are investing in a new center in North Haven. Those centers, which will house primary care and be able to have, you know, programs. I actually brought. See, this is I'm new at Yale, New Haven, but I can still sell. So I brought a little bit of a paper on the Shoreline Clinic and the services that are there. But you know, one of the things is that we ultimately will absolutely see more care being pushed out of hospitals. Now, the great thing with the St. Raphael's and Yale, New Haven integration is that that's the great flexibility that scale provides. We can move things around, and based upon demand, you know, we'll be able to adjust to those changes on a much more timely and progressive way than we would have if it was St. Raphael's and Yale, New Haven, incented to do whatever was the most economically self-interest that the system created. So we have much more flexibility than we had as two separate organizations. The challenge is in the meantime, we're still in a fee-for-service procedural-based system. So the concern, if I were sitting in your shoes or in anybody's shoes in this community saying, okay, that's great in theory, but right now you're high cost, St. Raphael's was lower cost, what's your incentive to drive that cost down? And that's one of those difficult things that we have to do it because it's the right thing to do. There's no paradigm shift at this point that tells us that the systems have changed to force us to do it. But I think I can tell you from the leadership, including Marna and the board, and collectively, we believe that we have to do it. It's not to say we're going back to Anthem Blue Cross and saying we want you to pay us less money. We certainly aren't doing that yet. But we aren't asking for the increases that we once asked for and being more aggressive than we've been. But we have some payers that, you know, frankly, we have to have difficult conversations with because, you know, it's not a single size fits all, as you can imagine. So I think that when you look at what's happening in healthcare, you look at what is happening here in New Haven, I think that there's a model that you're going to see, and it's not dissimilar to what you're seeing in other states. Merger and acquisition activity in healthcare is at an all-time high over the last year. You are seeing much more consolidation. Two major Catholic systems, Trinity Health and Catholic Health East, came together. That created the second largest not-for-profit system in the country. Those two systems would have never gotten together had some of the things that I talked about today of the changing landscape and environment. They would have never happened. So it's not going to be done. I think you're going to see a lot more change happen here in the state. I think that we still have a number of independent hospitals that certainly as Yale, New Haven, we're looking at from our system. How big should we be? It's not big just to get big, but it's really how do we ultimately create a platform that best serves this community and creates the right scale to do things that I talked about earlier. So I'm assuming that we will have other partners going forward. As I said earlier, we're going to grow our ambulatory network. I can guarantee you that we are going to have more consolidation of our physician practices that are right now very inefficient and scattered in, you know, relatively individual boxes. We're going to need to bring them together in larger scale to create the efficiencies that are necessary. And I think that's going to be pervasive across the country. So healthcare is changing. And I think one of the most risky parts of this change is how is it going to affect you and how is it going to affect your relationship with your physician. And I think that that's one that I believe will be enhanced because all of these changes are going to incentivize that relationship between you and your physician to be stronger, for the physician to do more before you're sent into the emergency department or in for a procedure. You're going to really have to understand what the implications of that are. And I think we're going to see that paradigm begin to shift slowly over the course of the next few years. So one of the questions that Randy mentioned, I'll close on this, is what are some of the changes? Well, with the re-election of the president, we do believe and now know that the rest of Obamacare, there are major changes happening in 2013 and 2014 that will take place. Here in Connecticut, we're one of those states that's elected to create a insurance exchange system. So, and it's likely that there's state employees will be the first group that will be entered into that exchange system. What is an exchange? It's creating a statewide, really a buyer network for insurance, and it's going to be a commercial-based plan that will be bid out to the insurers, so Cigna, Aetna, Anthem, etc. will be bidding on these 3 different plan sizes. Well, by 2013, we have to have that up. And by 2014, there has to be activity in it. So that's going to happen. That could really change some of the fundamentals of our employer-based coverages. Further, on 2014, we're going to see some major changes to reimbursement. There's some significant hospital reductions that are going to take place because of the expansion that's going to also go into that exchange program that I mentioned earlier with folks that right now don't have coverage. Luckily in Connecticut, it's not enormous. I mean, we have actually pretty solid coverage, but there are still a lot of people who fall between the cracks. So that crack will get narrowed significantly, and there'll be more people that will have options under that exchanges. So you're going to start to see some real things happen in the way that that folks are covered, the way that they're going to be seeking to have their relationships with physicians. And I think that, you know, when you look at Yale New Haven and what the opportunity is there, I think that that will be ready for that shift and be able to respond to it much more effectively than we would have independently. So that's my shtick, and hopefully I didn't bore too many of you. I would love to open it up for, oh, thank you. See, Mr. Tarutis is keeping me honest. So John Tarutis ran the System of Emerging Crime Center and now is continuing to run that. So we were nice to him, and he and I are still with us. So, so one of the things that he just mentioned is EPIC. So we have, Yale New Haven has invested over $250 million to implement a new $250 million. So 250, actually with St. Raphael's, closer to $300 million of investments to put in a new electronic health record. And this electronic health record is both outpatient and inpatient based. In order to do some of the things that I talked about, this is one of those prerequisite investments that we have to make. So within our system, all of our physicians will be on it, including the medical school. The 3 hospitals in our network will be on it, as well as Northeast Medical Group, which is our foundation where we house about 300 physicians. So there is a great effort. We're going to be rolling that out in New Haven in February and in June. On February on the York Street, Yale New Haven side, and in June on the St. Raphael's campus. So that will be a leap forward to enable us to do some of the things I talked about earlier. And that's one of those things that, as a strong performer and having some capital, Yale New Haven was able to do, and I think we'll be the beneficiaries as a community of that investment. Thank you, Mr. Truvis.
You forgot one aspect.
Oh,
Sorry.
you already corrected me on one. That's it. You've reached your limit.
You know, the beauty of the EPIC system is that it's also rolling out to the community physician groups. So your physician in the community we're going to be able to access your medical record and your history. And that really bodes well.
With your permission.
With your permission. So if you need a surgery, an elective surgery, let's say, we can access your record and see your medical history, your comorbidities, things you have going on now, and better manage your care. So it's a great leap forward for us. Really.
It is. And it's the Cadillac of systems. So large systems across the country have made the investment in EPIC. Because it is probably the most robust system that's offered on the market. It's a system though, and it comes with some challenges, but I think it will be a great platform to be able to meet some of these challenges that we forecast coming. Questions? Yes?
Do I understand you to say that when I go to Dr. A, I don't have to fill out a form with everything that I just filled out at Dr. B?
From your mouth to God's ears. You know, ultimately, but that's one of the costly things of our healthcare system. So, you know, we fill out papers, same ones, how many times? And God forbid you go see, you know, your primary care physician, a specialist, you go to the hospital for a diagnostic test, and then you go back for referral to another specialist, and then maybe even back to your primary care physician 2 months later, and rehab, and you're filling out things. It's not going to solve all of it. I wish I could say it would. We will get a lot better. So if you're on the EPIC system, and again, the thing is that not everybody will be on it, but if you're on the EPIC system, those core elements will be captured throughout the network. And the neat thing is, even if you're not on the EPIC system, there's a great tool within EPIC that's called MyChart that you can actually go in and access. So if you keep your med list updated, and you as a patient, this is new for this community, you have the ability to go in and use and view your medical record as well. I mean, that's like unheard of now, where you have to go fill out the form. It takes just probably 5 days to find it, to copy it, and then we charge you the $7.50 to get it back. Those days are going to come to an end. And while it won't be the entire record, it will be those key elements. So when was the last time that you had a colonoscopy? When is your mammogram due? Those types of really, I think, pieces of information that will help you manage your health are going to be at your fingertips. It's a great tool that when it gets fully loaded and there's data behind it, and it's going to take a little while to do that because we aren't going to be backfilling data in from our current system. It's going to have to be populated progressively.
But in my lifetime.
It will. Absolutely. I mean, February, we're close. February is only a couple months away. It's already dark and cold outside. Yes.
I'm aging.
Me too. Yes.
Yeah, you talked about being able to be a teaching hospital having higher costs. Are there special sources of money for teaching hospitals that are being set up?
So our system, Medicare has been built on. It's a very interesting system that I think we would do it very differently if we were recreating it. The entire burden of our teaching program has been paid by the government since 1985-ish, where we created two elements, indirect and direct medical education reimbursement to teaching hospitals. So there's an elaborate formula with the number of residents that you have and your costs that Medicare does pick up a portion of those dollars. It's declining, and then one of the elements that's very much under the attack screen, if you will, of the federal government is those indirect medical education reimbursement. And so as a large teaching hospital, as an academic medical institution, we see that very much at risk. And on the other hand, so you have that being decreased, and then you have a physician supply issue that is, a shortage that is happening as well. So, those are big challenges, and certainly we're going to be advocating with our legislators to say, be careful. You're going to have a major impact on our ability to meet the demand going forward if you make, silly cuts. But on the other hand, we also know that we can't be as costly as we are. So, we have to do the right thing, but we still feel like we have an obligation. It costs a lot of money to have the infrastructure to be the transplant center. It costs a lot of money to be, the one who's doing a lot of the clinical trials and being on the cutting edge. Those things are expensive. And how much are they valued? And we're going to have that discussion. And again, it won't be overnight. It's going to take a long time. But I think those are at the root of this debate that are ultimately going to have to play out with, where does the funding come from? Yes?
We're going to integrate cancer care in my
The interesting thing is that, these are some of the secrets that we keep. Cancer care is actually beginning to be integrated before the transaction even closed. So we had a private practice of hematology oncologists, that actually moved over to the Yale faculty in January of last year. So 9 months before we actually closed the transaction, they were part of the Yale medical group. In July, our radiation oncologists, the folks that deliver the high-dose radiation, moved over to the Yale medical group. So we were already beginning the integration with the Smile Cancer Hospital before we actually began the transaction with Yale New Haven. At the end of the day, what does it mean? Well, it's going to mean a couple of things. One, with that common database and platform, we certainly are going to have the ability to share information between the McGivney Center and Smilo. Smilo is growing considerably. It's actually created a number of outposts around the state. And that network is going to be, I believe, hopefully in the long run, opportunistic for clinical trials and enabling sharing of resources and information. But you will see probably very little in the change of how your interaction takes place with the physician. Cancer, for the most part, is an outpatient delivered service. When you do need inpatient care, our inpatient services at St. Raphael's before the transaction were declining considerably with the beautiful and significant investment at Smilo. Most of that inpatient care is already being delivered at the Smilo Cancer Hospital, and that will probably continue to be integrated over time as well. It's really a beautiful center. So, you know, and we had one floor on our third floor of the Bertie unit that was old, and you know, probably if you needed inpatient care, it makes a lot of sense to go to the newer facility. So those are some of the things. It's not going to happen today or tomorrow, but over time, I think you're going to see some of those things be consolidated. But at the end of the day, we're still going to be doing chemotherapy. We're still going to be doing radiation therapy. We're still going to be having significant outpatient visits, testing, procedures, all of those other things that surround oncology care will continue to be done on the St. Raphael's campus, certainly as well. Yes?
Well, when you speak about shortages of primary care clinicians, if there's any discussion with the School of Nursing and its preparation and use of more nurse practitioners and clinical projects?
So there's a couple of things going on in the supply side. One, we have the addition of the Quinnipiac Medical School, which will be focused on primary care. I believe that that's a real advantage for this area because, you know, while they will not have a formal affiliation with Yale New Haven because of our affiliation with the Yale Medical School, I believe we'll be able to produce more, and many will stay in this area, and we'll have an opportunity to engage them during their training. Medical school. So I'm going to start with doctors and primary care because that's what I started with. Now, you're absolutely right. What we're also seeing, and I'm going to go back to Quinnipiac, who is probably more advanced in their School of Nursing in terms of their ability to put people into their system. The Yale Nursing School has a little bit different focus. So I think that there is going to be a high demand for those services from advanced practice nursing. We're going to see more of it. We already are. At St. Raphael's, we had a number of APRNs that were doing independent licensure type functions within several of our key clinical programs, bariatrics, joint replacement, spine, a number of these programs where nurse practitioners and advanced practice nurses could really help be an extender of the physician and the care pathways that we develop. So I think we're going to see a lot more of that. And yes, primary care. I think that there's still some distance to go. Typically right now, there are not a great deal of, hang your shingle and be an independent nurse practitioner freelancing kind of on your own in this community yet. It's more integrated into a large group where they've become a vehicle for access, and they work in coordination and collaboration with the physicians. So I think that will continue to evolve. Where it goes, I quite frankly don't know. But if the supply side is constrained, we're going to have to react to it, which means we're probably going to give greater latitude to those nurse practitioners and physician associates to provide care in the community. I said it in the back, didn't I?
How are you integrating both campuses? Are you changing things, or are you keeping them relatively the same in terms of?
So part of our, it's a great question. So part of our commitment to the Federal Trade Commission when we went down and argued that this makes sense to do, and these are some of the reasons, was that there was this bed shortage on the Yale New Haven campus. Right now, we have increased the average daily census about 24 patients a day since the merger. So we've only been as one organization for about 2 months, and we're already well underway to shift some of that. Unfortunately, we're backfilling it with other demand because it hasn't lightened the capacity on the York Street campus yet. But we are occupying more beds on the St. Raphael's campus and moving more patients through that system, which I think is the right thing to do. Yale New Haven, when we went in, we invested money into 2 empty units that we had closed because we just didn't have the volume to support them. One is opening in 2 weeks. Actually, Census, Louisiana, 3 is opening in 2 weeks. Celatano 3 is opening in 2 weeks. And then we are doing a major renovation on our 34 North unit, which will be open sometime in the spring. So we're opening beds on the St. Raphael's campus, which was part of our argument. We have not moved any clinical services. Everything that was there is still there. We are going to be closing down. We had a 3-bed pediatric unit that we had an average daily census, which means, bless you, we had an average daily census means on a regular basis there was less than 1 baby. We don't cut them in half, but less than 1 baby in our hospital on a regular basis. That's going to move over to the Children's Hospital. That's a kind of a slam dunk. Frankly, we didn't have subspecialty care. We didn't have, I probably would not admit my daughter to that unit because of the lack of volume and support. So that's happening right now. We are looking at other areas, trauma, for instance. It's very expensive to have 2 trauma programs. A city of our size doesn't really require 2 trauma programs. It's not good because my mother's the trauma coordinator at St. Raphael's. But looking at how do we bring those together and share resources and ultimately create that economies. Other than that, I mean, we have a lot of work that we have to do just to stabilize what we're doing now. So we're probably going to be moving more care to St. Raphael's, and for the obvious reasons, Yale New Haven is at capacity, then we are shifting volume away from St. Raphael's. But that was one of the major concerns as I was meeting with employees and physicians on the St. Raphael's campus leading up to the integration. What's going to change and how is it going to affect me? And right now, very little, other than we're getting more volume and hopefully creating more vitality on the campus. Yes.
What's going to happen with psychiatry? I have students at Yale, and I think they're
Psychiatry, well, that's dangerous if the tension's comparable in psychiatry. It could go lots of different places with that. But I think, frankly, mental health is a major area of concern for us as we look forward. Much of our ED volume that we look at it, there are typical comorbidities between mental health and substance abuse that right now we don't have systems. There are, just poor infrastructure to care for those patients over a long period of time. We're at 100+% capacity on both campuses for psychiatry. We are going to keep it. Our commitment is to keep it on both campuses, but it's a major area of concern for us in terms of how do we recast the system to be able to manage those folks who have chronic mental health issues. We can handle the acute issues. I think those are a little bit easier to address in terms of what we've built and what we're prepared for. But what we don't have is the system to really deal with the more chronic mental health and substance abuse issues. And so it's going to grow, not shrink, unfortunately.
You said you don't have a
crisis unit?
So we don't. We collectively now as Yale New Haven do not have one on the Chapel Street campus. See, I'm going to get mine on the St. Raphael's campus. But we had talked about building one over, for several years. Yale New Haven does, but they have a whole psychiatric hospital. So, again, how do we take best practices and ultimately create that standard of care that is better for those patients is something that we have to, we'll have to look into. That's probably a more longer-term project because right now we're at capacity, so we don't have any place that we could do things, unfortunately. And the system does not reimburse us enough to build a new center. I mean, you could literally build as many beds as you want, and they'd probably all be occupied. You get calls every day from other hospitals around the state hoping to place patients in our institutions, and there's just not enough bed capacity, which speaks to the larger issue. So we are engaging the state of Connecticut in terms of are there different ways we could look at it, and ultimately, again, similar to accountable care with mental health, how do we ultimately shift it out of the hospital and create more longitudinal types of care delivery systems that will both address the needs of those patients at a lower cost, but also reduce the incidence of acute hospitalization needs.
Connecticut seems behind the times in many ways, but in having psychologists work with primary care clinicians. Kaiser has that model in place. New York does, and we're trying to be Connecticut down there because the estimate is 70% of patients are coming from their care have underlying depression, and if we can address those, they might be.
Well, it's, I think one of our faculty made the statement that if we could just populate the entire region with child psychiatrists, we would solve all of the long-term healthcare needs of the community. I think that the answer is yes, that ultimately that's what I'm referring to, that the paradigm and the model that we're currently using is going to have to shift. And you're absolutely right. We can look to the Kaisers and to the Geisingers and to those other more integrated systems as examples of what may be efficacious in this community. But I haven't looked at it enough to speak intelligently about it. We have to do something different. Yes?
So can you talk a little bit about how you see things going with Obamacare and then, of course, with your efforts to reduce costs in terms of Medicare and supplemental insurance or the Advantage type insurance to go along with the AAP?
We could spend all night talking about it. It's a incredibly detailed question, but I think at the end of the day, it's going to come down to we're going to have to, as John said, with the EPIC investment, we're going to have to coordinate care far more effectively than we do right now. We're going to have to shift from this episodic, procedural-based influence that we have grown up with and we have been living in and we've been paid by, to more of that long-term continuum that I talked about. And ultimately, we're going to have to do it for less because I don't think we can sustain the inflationary rates that our current system has experienced over time. So when you combine some of those core factors, and there's many, many others, how do we deal with it and what does it ultimately mean for us? Well, that's part of why scale becomes important because we can't be both putting in intraoperative MRI systems for $10 million a piece because that becomes a standard of care. It makes no sense when we only do 150 of those types of procedures between the two institutions a year. You can clearly utilize that in a single unit. Da Vinci robot systems, it's a $2 million investment. How many of them do you need in a community of this size? That's what we're going to have to work more efficiently towards, which is what is the right technology to balance for patient need, not what do we need to do because the financial incentives tell us we have to do it. And we'll keep buying MRIs and CT scanners, and we do more images than we know what to do with. But ultimately, is that providing better care? Well, most of the literature says probably not. And so where does it ultimately land? I don't know, but we have to be ready to respond to it. And certainly by creating the scale, you're in a much better position to respond to those changes as society, government, and policymakers and legislators begin to evolve this system. But it's going to be hard. I mean, you saw what happened when people started to talk about, you may not have access to the same procedures or tests that you want. I mean, it became labeled as death panels, and a little bit of media and opposition hype, and hyperbole. But ultimately, that's this balance that we're going to have to get into: is what is the right care at what cost?
And do you think then that so with the supplement plans that you can purchase now to go with Medicare, do you think the government's going to push down more requirements and drive up premiums? That's going to be out of pocket, or how do you see that?
I think it's too early to tell. I think we'll know a lot more when these exchanges get created and priced, because until they go into market, it's impossible to predict what the price points are going to be. We know that there's going to be heavy subsidization for 400% of the poverty level here in the state. I believe that's the right number that the ACA requires. And so some of those things are kind of pre-programmed, but how it's individually costed is going to be done on a state-by-state basis. So a lot of that stuff, I think we'll know a lot more in 2015 after these things get rolled out and we see where we are. And again, you heard during the election, many states have opted not to participate. So what is going to be the differential between states that do and don't, and ultimately how is that going to fall to the federal government to equilibrate the the cost structures between the do's and the don'ts, or the haves and the have-nots. Yes.
Comment a little bit, if you could expand on the decentralized centers like the Shoreline in Guilford and your New North Haven and maybe any other like that. Is there a possibility of offloading some of the central campus functions to some of those, and what kinds of things make sense? Are you looking at all of that?
So it does offload from York Street. Clearly, outpatient procedures, office visits, etc., are now happening in the community, which I think is the right thing. The other thing is, because like Goose Lane is a pretty sizable spot, and you look and there's lots of Yale New Haven sites. Again, my selling. I brought a list just because I was curious. So some of this is my learning, but of all of this is just now Yale New Haven. So within the New Haven area, of all of our sites. So I mentioned two, North Haven and Guilford, because they're the larger scale outposts, if you will. The fact is that we have a lot more smaller, less efficient places. I think you're going to start to see more consolidation in those sites and having bigger boxes, if you will, that will become more efficient, centralized scheduling, more efficient use of radiology and laboratory. You don't need multiple draw stations. You have them in one place versus having 6 people drawing blood. You can have one. Those types of aggregation, I think you're going to see, and it's similar to what's happening in the hospital side, but you're going to see that in the ambulatory side. So I believe, yes, you will see more of that, and yes, the desire is to move what makes sense from the high cost downtown cost structure to the community, which we can do it at a lower cost. So I think that will continue to evolve as we go forward. And we're going to be opening more of those sites, I can almost guarantee it. Yes?
Just to bring it home to Shoreline Village, what advice could you give our group or groups like ours to begin to build sort of a strong, informative, and supportive relationship between our organizations and the major healthcare providers? I'm thinking, for example, that a point of overlap is between many of the people that you discharge to recover at home and people that will be in our system. What is sort of a good point of entry to start a conversation and build a relationship, say, beyond the care?
It's a great question. Actually, Ren and I talked about it when, in the earlier stages of the village. And I think it's going to begin, like many other things, with an education to our social workers that are doing the care coordination to understand what it is, how it can be advantageous to help. in terms of the continuity of care for our patients who are going back into the community. I think it's also going to be the maturing and more visibility and stronger presence of the villages around the state. You know, ultimately, the more communities that we have, the larger the call will be to support one another for different levels of care, and you know, without obviously getting to the point where there's clearly a need for some institutional support. But I think that it's going to be an incremental education process, and then ultimately a care coordination process. So, you know, EPIC becomes a great tool. How do we provide information for what the level of services are? You know, how we are tracking, you know, the activities of daily living against, you know, and to a point where they can sustain in the village versus maybe needing an escalated level of care. I think those are things we're going to have to work together on. And as I said earlier, I think the payment mechanisms are going to incent us to be at the table, but not just the village and the hospital, but with nursing homes, with assisted care facilities. I mean, I think we all have to do a better job of coordinating the way that we deliver care to our community, and right now we don't. It is incredibly fragmented, and so I think that's the call. And the great thing about EPIC is it provides a platform. How we use it and how engaged it is, I think will be to be determined. But at least it provides a data source that we can have these conversations. We couldn't do it without that tool, or it'd be very difficult to do it without that tool. There'd be lots of handoffs and manual pieces to make sure that folks had the right information to get the care and services that they need.
With HIPAA, do you see Shoreline Village type organizations having, you know, some sort of access, limited or otherwise, to support their members?
Well, again, the patient will have access, and that's why I talked about the My Chart. So then it becomes the patient's power to disseminate with the village without getting into our HIPAA regulations. But they can then work with the village to say, these are the services that I believe I'm going to need, and you know, let's come together and see if that's the level that can be supported. And I think that's where that tool becomes a powerful mechanism for that discussion.
So of course, one last thing. For those at the hospital who are thinking about community investments, I think investments in organizations like ours that are just getting started and that are getting organized would be enormously helpful in sort of not only incentivizing but sort of boosting these organizations so that they can begin to set up structures that then can be fed for the populations who would most benefit.
Yeah, and you know, always the tough thing will be the dollars, because you know, there's lots of things that could eat our resources. But you're right. I mean, it's hard to argue. It makes total sense. How to do it, on the other hand, I think it's something that we'll have to.
Well, maybe Randy will come in and talk more.
We're working on it. Yes.
How user-friendly for senior populations is the EPIC system going to be? If, I guess my question would be, I think the senior population in the United States is nowhere near as computer literate as, say, your generation. And if your generation is developing the EPIC system,
Not much younger than me.
so that you know the younger generation is comfortable with it, does that potentially leave out a significant population?
It's the right question, but the fact is that you would have to have your head buried in the sand to not realize who are the heaviest utilizers of healthcare services. So it is imperative that the system, and it is, be very intuitive, very user-friendly. The MyChart system, for instance, is very straightforward. It's not a lot of lingo and jargon that gets people, you know, somewhat confused. But nonetheless, it's a tool. And you know, the principal person that you need to work with is your physician. That doesn't change. But it becomes an empowering tool when you walk out of the physician's office versus saying, you know, I forgot to ask what my level is, or I didn't write that down, or I forgot to ask that question. It becomes a tool where you can go home and access some of those pieces. And if you can't, it's going to be incumbent upon us, the health system, to put resources in place to help you with that. So, you know, right now as we roll it out, it becomes, I can envision having help desk type services where you can call centers to call in and ask questions, you know, how do I access it, or is this available? I mean, there clearly is going to be an interface that will have to take place between the providers and you in the community to make sure that you understand what the opportunity is to utilize. So that's in the forefront of our mind as we go to implement.
That's what it's got. I think that could be a role of the village.
Yeah, that's a great point.
You know, we have a wide age group, very diverse. We can link up with younger people, high schools. You know, there's no reason why we can't do it like that.
Right. That's a great point.
Isn't it already operational in parts of Boston where you can access your medical record online?
Yeah, so there are other systems that have it. I mean, Partners has developed an internal system in Boston that you can go on the internet and access parts of your medical record. It's out there and available, but we don't have anything like it in this community yet. So that's the real, I think we're going to start to at least be on a footprint that is more like others than less like others without it in the past. So, and it's been a big advantage and well received from the folks in Boston. Yes.
Just one comment about my chart out medication visit through a doctor's visit. It's really quite simple in nursing homes.
Yeah. There you go.
You mentioned ACOs a couple of times. Yale and
So, you know, again, as I also said, ACO means a lot of things to a lot of different people. There are lots of definitions around it. I think the answer inevitably is going to be yes. Just what form does it take? So we have already put in an application with Medicare for bundle payments. I think I mentioned that earlier. That's one of those mechanisms that ACOs help to manage because you have a coordinated system. We have to build primary care, we believe, in order to be an effective ACO. So we're trying to do that. That's a major strategic imperative for the system to build our primary care network, not just within the hospital territories that we serve now, but across the state, because we believe it needs to be a much wider network. But I think that inevitably we're going to have those tools and that capability to serve the population. You know, they talk about population health, medical home, ACOs. These are all things that we're going to have to be participating in. All right. Well, thank you for the opportunity.